Hi everyone, in this video I'll be discussing a topic called anti-arrhythmic drugs. So before starting this topic, it's important that we understand what you mean by arrhythmia. The name itself is telling you there is a rhythm disturbance in the heart. So either the heart is beating too fast or the heart is beating too slow. Now what is the reason for arrhythmia? Most commonly the reasons are MI or the drugs itself can cause arrhythmia if they are in high dose, or the toxins or the electrolyte imbalance, even hyperkalemia, hypokalemia, these things can cause it. So why should we manage this? There are certain arrhythmias which are immediately dangerous to the life. For example, ventricle fibrillation. What happens if ventricle is fibrillating? When the ventricle is fibrillating like this, it cannot effectively pump the blood out. If it doesn't effectively pump out the blood out, patient may die. So it's important that we manage the arrhythmias. Now, when we are managing arrhythmias, please understand to check whether the patient is stable or unstable. So, stable means the patient BP is okay, more than 90 millimeters of mercury, that is okay. Unstable means BP is low, hypotension. So, yes, arrhythmia and hypotension, then unstable patient we have to do DC cardioversion, shock has to be given. If the patient is stable, then only we give the drugs that is called pharmacological cardioversion, and then the role of drugs come. So with that brief introduction, let us start antiarrhythmic drugs. To understand this, first of all, we need to correlate some physiology, and then you should know what are the types of arrhythmias, and then only you will understand pharmacology. So we go in a sequential manner. So let's start. So antiarrhythmic drugs. So before understanding this, you should have an idea. What do you mean by arrhythmia? The meaning is the heart is not beating in the rhythm, either it is beating too fast or too slow. So basically, there are two important arrhythmias, the bradyarrhythmia, and one more is the tachyarrhythmia, where the heart rate is high. So usually the heart rate is between 60 to 100 beats per minute. So less than 60 or more than 100 is going to cause, less than 60 is going to cause the bradyarrhythmia, more than 100 is going to cause tachyarrhythmias. So normally it should be 60 to 100. Now, what is the causes for arrhythmia? I told you, it may be because of MI or drugs. For example, digoxin can cause arrhythmia, or toxins, or electrolyte disturbances. Now, what is the problem? There are nodal tissues. So nodal tissue, you know that SA node is the one which generates the impulse. So the problem is in impulse generation. Sir, what do you mean by impulse generation? The SA node is either generating too fast, tachycardia, or too slow. Or the problem is in impulse conduction. The problem is in impulse conduction. So there are conducting system of the heart. Either they are conducting too fast or they are not at all conducting, for example, heart block. So we understood the basics now. Once I understand the basics, let us understand what are the arrhythmias we are going to commonly see in the practice. So let us see that. So let me draw the heart. Yes. So the heart, so I'm just dividing it into atria and ventricle. Now we know that the conducting system of the heart starts from the SA node, and the SA node has a connection with the AV node. So from the AV node we have the bundle office, and from the bundle office there are fibers called Purkinje fibers. So this is the conducting system of the heart. If I want to compare with the car, the first gear is SA node, second gear is AV node, and the others are the third gear, fourth gear, fifth gear. So as you move on, the speed increases. So obviously the slowest conducting tissue will be SA node, and that's the reason that is the pacemaker. And that's why in car you have to start with first gear only, and then only it will move. So SA node is the pacemaker. This is the SA node, and this is the AV node, and the bundle of fins and Purkinje fibers. We got it. Now, what are the arrhythmias which originate from atria? First of all, let me do one thing. I will tell you what are the arrhythmias which are slow heart rate. So patient may have bradycardia. The heart rate may be less. Or the second problem is patient may have a heart block. Patient may have heart block. Heart block means there is a problem with conduction of AV node and we call it as AV block. Now already we know these drugs to treat bradycardia and heart block. Can you guess what are the drugs used for that? Yes, you're right. The drug used to treat bradycardia as well as heart block, the main drug is atropine. So atropine can increase the heart rate, increase the conduction. One more drug that can be used is isoprenaline. These are the drugs which we can use to manage these arrhythmias. So I told you the arrhythmia may be a problem in impulse generation, that is bradycardia is seen, or impulse conduction where the impulse conduction is blocked. So these are the bradyarrhythmias where the heart rate is less. Now let us take into consideration tachyarrhythmia where the heart rate is high. Now the arrhythmias which arise from the atria, we have something called PSVT. So PSVT stands for paroxysmal supraventricular tachycardia. The name itself is telling you supraventricular means above the ventricle it is arising. Now one more is SVT. In SVT, the heart rate will be around 150 to 200. So the atria is at 150 to 200 beats per minute. Then we have another important one, and that is called the atrial flutter. In atrial flutter, the rate in the atria will be around 200 to 350. Yes, and one more, the atrial fibrillation. In atrial fibrillation, the rate is still high. It's around 350 to 500. Yes, okay, sir. So PSVT, SVT, it's around 150 to 200. Flutter 200 to 350. Atrial fibrillation 350 to 500. So that means this is the atria above, ventricle below. Now if the atria is generating the impulse, all the impulse will not come to the ventricle because we have the second gear, that is AV node will block it. So whatever impulse you give. But there is still a risk that this impulse may come to the ventricle. So along with this AV node, we have to give the AV blocking agents. So we already have studied in pharmacology, CVS Pharma, there are drugs which can block the conduction. So can you guess what are the drugs which can block the conduction and used in atrial flutter and atrial fibrillation? Can you guess? Yes. Can you use beta blockers? Yes. We can use beta blockers. And you know that beta blockers can block the conduction so that from the atria, ventricle, the impulse will not come faster. Or we can use the non-DHPs. What is non-DHPs? Non-DHPs are calcium channel blockers. So can you give an example of that? The name is called verapamil. It is called verapamil. One more drug that can also block the conduction is digoxin. So we use beta blocker or CCBs or digoxin, usually preferred is beta blocker. If it is not there, verapamil, very least nowadays preferred is digoxin. So all these three drugs what you have written, they are called as AV blocking agents. So these are AV blocking agents and they will not allow the atrial impulse to go to the ventricle too fast, they will block it. Similarly, SVT, PSVT, we have a drug called adenosine, we'll discuss it later. Now, sir, okay sir, we managed it fine. Now another important arrhythmia what I need to understand is in the ventricle. So in the ventricle, we have a problem called ventricular tachycardia. So the impulse may get generated in the ventricle and there is ventricular tachycardia. And one more dreaded complication, patient might die because of this, that is called ventricular fibrillation. So patient may have ventricular fibrillation and one more condition is called pulseless VT. So pulseless VT and ventricular fibrillation are an emergencies. Patient is unstable, obviously in that. So in these cases, what we do is we have to defibrillate the patient. So defibrillation has to be done. And then only the drugs are required. So we understood the basics. In this diagram, we know that these are the arrhythmias and how do we manage them. But the problem here is, what I told you is, when there is atrial fibrillation, what I did is, I only blocked the conduction, but still the atria is fibrillating. Still the atria is fibrillating. Now you have to make the fibrillation into normal sinus rhythm. It has to come to the normal. So there are certain drugs which are used to make that rhythm normal. So I told you, to make the rhythm normal, there are two ways. Either you can give the shock, DC cardioversion, and when do we use it? Yes, when the patient is unstable. If the patient is stable, then we use the drugs and we have to make the rhythm to normal. So that's the reason we have to learn other drugs also, apart from this. So with that basics in the mind, let us understand how to bring the rhythm back. How to bring the rhythm back. This is the basics now. To understand how to bring the rhythm back, it's important that we need to understand some cardiac physiology. So I'm not going in detail. A bit of cardiac physiology is important because why the arrhythmia is occurring? Because the impulses are coming again and again and the cardiac muscles or the conductive tissues are getting fired. So you have studied in physiology, there is a period called refractory period. What do you mean by refractory period? Even if you give one more stronger impulse, the tissues will not react. So in arrhythmias, we should make the tissues refractory. Sir, how do I make it? That's what we'll learn now. Now, first of all, this is the action potential in the ventricular fibers, atrial fibers and Purkinje fibers. Remember, these are the fast conducting fibers. I told you they are like third, fourth and fifth gears, right? Now, I have written the diagram here. You can see in the graph, the x-axis, the time, y-axis, the membrane potential, and usually the membrane potential, that is resting membrane potential in the ventricle and atria is negative minus 90 millivolt. Now, how does it become positive? The positive, that means the graph will go up when the positive ion enters the cell. So when the sodium enters into the cell, then it will become positive. So it keeps on moving up until it reaches the peak. So when it reaches the peak, then the sodium channel closes. So the sodium start entering, and when it achieves the peak, the graph stops there. So this is called the phase 0. So once it achieves the peak, then what happens? The potassium keeps on coming out. So when the potassium goes out of the cell, obviously the membrane potential try to become more and more negative. So the graph falls down. So that is called the phase 1. Phase 1. Now after that phase 1, what happens is the potassium keeps going out. Potassium keeps going out, and who comes inside is calcium. So the potassium keeps on going out and who came inside is calcium. So since one positive ion and another positive ion is coming inside, it will be plateau. So the second phase, that is called phase 2, is called as the plateau phase. You can see the line here, it is flat. Now once that phase 2 is done, then the calcium channels will close. Then who is the only one who is going out? That is potassium. So potassium is the only one who is going out. And so at the end of phase 3, this is called the phase 3, the potassium will stop. Now you see the graph and tell me who is inside the cell now. Sodium is inside, and who is outside? Potassium is outside. So again the cell has to come back to the normal position, that is in phase 4. So phase 4, what happens is, who is outside? Who is outside? Can you tell me who is outside? The potassium is outside, so potassium comes inside, and who goes outside is sodium. So how much potassium? 2. How much sodium? 3. Sodium goes out. Again after that you get the same action potential like this, right? So we get the same action potential and it continues. Clear? So we have repeatedly phase 0, phase 1, phase 2, phase 3, phase 4. I'll explain again. Phase 0 is a point where sodium enters inside the cells and you get a positive. That is, the graph goes up. And after the peak positive is obtained, it will stop, sodium channel closes. Then potassium keeps on going out, so the graph falls. That is called phase 1. And there is a plateau phase. Because the potassium goes out, calcium comes in. There is a balance. At the end of phase 2, the calcium channel also closes, only potassium goes out. So that is called phase 3. And after that, phase 4, who is outside? Potassium. Who is inside? Sodium. So they get exchanged. Sir, okay sir, we all understood this. But why are we studying this, sir? Now to understand this, let me draw this again for you. This is the phase 0. This is the phase 4, phase 0. Then 1, then 2, then 3, again 4. Now I told you there is something called refractive period. That means you cannot excite a tissue. Now until the phase 3, this is the phase 3. So phase 0, phase 1, phase 2, the tissues are in absolute refractive period. So in these phases, we have the tissues in absolute refractive period. In that period, whatever impulse you give, they are not going to get excited. Now, after this, there is something called relative refractive period, which is seen in phase 3. There, if you give an impulse which is stronger, you can get another arrhythmia and another impulse can get generated. So, we call it as early depolarization. So, they can be having one more action potential there and it can cause arrhythmia. Or there may be delayed action potential that can get generated in phase 4 also. So this is called delayed after depolarization. So this is the potential places where the arrhythmias can happen. But let's not worry about that. What we are going to understand here is, please remember the tissue has to be made refractory. Now tell me, how do I make the tissue refractory? You check the diagram and tell me. 3 and 4 I cannot do because the stronger impulse can generate another impulse and arrhythmia can progress. Whatever I have to do with 0, 1, 2. So what should I do? I have to slow the process of sodium entry. I have to slow the process of potassium entry. I have to slow the process of calcium entry. So if I do that, what happens? The refractive period will increase, or that durations will increase, and one more impulse cannot stimulate the tissues. So that's why we have drugs called the sodium channel blockers, then the potassium channel blockers and the calcium channel blockers, which are going to work on this. They are going to work on this. So either we block the sodium channel, so the sodium enters slowly and action potential is not generated faster, or we can block potassium channel, or you can block calcium channel. So we have 3 targets right now to treat arrhythmias. Let me repeat: sodium, potassium and calcium channel blocker. All are blockers. Okay sir, this is about the ventricle, atrial, Purkinje fibers. Sir, what about the nodal tissue, sir? Can you do anything with that? Yes, we can do. What is that? What is that? This is the action potential of nodal tissues. That means the action potential of the SA node. Now in SA node, the resting membrane potential is around -60, not like that. Now here, this is called as the phase 4. This is called as phase 4 of diastolic depolarization. Now can you tell me what happened in phase 4 there? Can you tell me? There, sodium was going out, but here in this place in phase 4, the sodium is coming inside. Since this is not normal, this is funny. That's why these sodium channels are called funny sodium channel. I think you heard of funny sodium channel somewhere. Yes, where? In anti-anginal drug, there is a drug called ivabradine. It inhibits that. Now why the nature has done the sodium to come in the phase 4 so that the automaticity is maintained. So as soon as the automaticity decreases, sodium enters, then you will get one more action potential. So to maintain the automaticity, Sodium keeps on coming in phase 4. Another important thing is in phase 0, here in SA node and AV node, who is coming inside is calcium. Compare there, it was sodium, here it is calcium. So calcium is coming inside. And who is going out is potassium. So there is only phase 0, phase 3 and phase 4 in SA node and then AV node. There is no 1, 2. So the difference here is in phase 0 calcium is entering and in phase 4 sodium is entering. Suppose you want to slow the heart rate, what to do? Slow the heart rate, what to do? Tell me. Come on, you know the answer. Just pause the video and try. To slow the heart rate, you should not allow the sodium to enter faster into the phase 4. So that's why we have a drug which inhibits the funny sodium channel, and that is called ivabradine. Ivabradine is not an antiarrhythmic, but I am just correlating here. The name itself is BRAD, it decreases the heart rate. Now how does it decrease the heart rate? When we don't allow sodium to enter, what happens? I'll just trace here. The slope of phase 4 decreases and the heart rate keeps on decreasing like this. So the heart rate keeps on decreasing like this. Okay. So it decreases the heart rate. When you decrease the slope, the sodium doesn't enter faster, so heart rate decreases. So that is ivabradine. Now the nodal tissues are controlled by two important receptors. Let me tell you that. That is also interesting for you. I'll just tell you. So let me write the SA node. This is the SA node. Okay. Now very important, careful. In the SA node, we have a receptor for beta 1, and we all know that beta 1 is a GS coupled receptor. What does it do? It increases the activity of cyclic AMP, and that will allow the entry of sodium inside the cell, calcium inside the cell, and it will not allow the potassium to go out. So that means when the sodium enters, calcium enters, obviously there is increase in heart rate because they are going to stimulate. Correct? Then you have the opposite of this. The receptor which is present in the heart, there is M2 receptor and it's a GI coupled receptor. So what does it do? It decreases cyclic AMP. So what happens if you decrease the cyclic AMP? It will not allow the entry of sodium inside. So it will not allow the entry of sodium. It will not allow the entry of calcium. So what happens? The potassium can go out. It opens the potassium. So what happens if you open the potassium? The cell will become hyperpolarized and the heart rate decreases. So the M2 can decrease the heart rate, beta 1 can increase the heart rate. Suppose you want to decrease the heart rate in tachyarrhythmias, what should I do? You have to give the beta blockers. And we have beta blockers as antiarrhythmic drugs. Another important point I was telling you, the calcium is entering inside. Block it. If you block the calcium, the heart rate decreases. So CCBs are also used in the arrhythmia and they can also act on the nodal tissues. They decrease the heart rate. And I told you, what are the calcium channel blockers we are dealing with? That is called verapamil. And one more is diltiazem. Verapamil and diltiazem, right? So these are the correlation between physiology and pharmacology. I just want to summarize the things. Now, there is a difference between the action potential of the ventricle and the nodal tissues. Ventricle and atrial tissues, the phase 0 sodium enters, then phase 1, phase 2, phase 3, phase 4 are there. But in nodal tissue, there is only phase 0, phase 3 and phase 4. But in this phase 0 nodal tissue, the calcium enters. In phase 4, the sodium enters. That is called funny sodium channel. Now, the purpose of an antiarrhythmic drug is to slow this process, particularly in tachyarrhythmias. So, either they block the sodium channel or potassium channel or calcium channel, or they block beta blockers. I mean, they will block beta receptor. That is called beta blockers. So, these are the classes of antiarrhythmics we have. Okay. Now, I just want to add one more point here. Very interesting point. Now what happens, sir, if I block potassium channel? So what happens if I block potassium channel? This is the phase 0 and the phase 1 and phase 2, this duration gets prolonged. So this is called the action potential duration. This becomes prolonged compared to normal, this becomes prolonged. So the ECG has the P wave, the Q wave, then the R, S and T wave. So this is the P, Q, R, S and the T wave. So the interval between the Q wave and T wave is the QT interval. Now what happens when you increase the action potential duration? Any drug which blocks potassium channel is going to cause QT prolongation. The meaning is they can increase the action potential duration. Now what happens if you block the potassium channel? The refractory period also increases. What is the advantage if you increase the refractory period? The tissues are not excited. And that is the purpose what we are discussing now in anti-arrhythmic drugs. So these are the potassium channel blocker. Remember, any potassium channel blocker in the heart are going to increase the action potential duration and they are going to increase what? Refractory period, particularly absolute refractory period, and in the ECG they cause QT prolongation. But if you excessively block this, it can cause arrhythmia called long QT syndrome. So there is the basics we need to understand about the pathophysiology and pharmacology. Okay, so we know the targets that we need to block sodium channel, then potassium, calcium channel and the beta blockers. So there is a classification given by Vaughan William Singh. So let us classify that. So classification of antiarrhythmic drugs, and that is given by Vaughan William Singh classification. So according to them, there is class 1 antiarrhythmics and they mainly block sodium channel. Then we have class 2 antiarrhythmics, they mainly block the beta receptor. Then we have class 3 antiarrhythmic, they mainly block potassium channels. Now class 4, they are non-DHPs like verapamil diltiazem, they are called CCBs. So basically we have 4 important classes. Many a times it's important that we should not forget this sequence. There is a mnemonic for this. The mnemonic is saved by pharma class. So whenever you have a doubt about this, what is class 1, class 2, class 3, class 4, remember the mnemonic saved by pharma. S for sodium, B for beta, P for potassium, C for CCBs. So this is the 4 classes and the last one is miscellaneous group. So all other like atropine, digoxin, they all come under miscellaneous group. We'll discuss them later. Okay, so we'll go one by one. First we'll take up the class 1 antiarrhythmic and then other things. Okay. Class 1 antiarrhythmics. What are these? Class 1 antiarrhythmics are sodium channel blockers. So class 1 antiarrhythmics are sodium channel blockers. So we have 3 important categories in that: 1A, 1B and 1C. So we have 3 important subcategories in that: 1A, 1B and 1C. Now to understand this, you need to understand that sodium channels on the cell membrane exist in 3 forms. Let me write that. This is the sodium channel on the cell membrane, right? This is the sodium channel and there is a gate to close this, that is called M gate. This is the M gate and it has one more gate called the H gate. Now this is the entry point for sodium. The sodium enters here into the cell. Now because the M gate is closed, sodium cannot enter. This is called a closed state of sodium channel. This is called the closed state. Now once the sodium starts entering, that is in phase 0, when the phase 0 starts, sodium has to enter. Now what happens here? This is the same here. This is the same here. Now what happens? The M gate opens up. The H gate is still open. Now the sodium can enter inside. the sodium enters inside. So this is the entry, that is phase 0. This is the phase 0 and the sodium enters inside. And this state is called the open or the activated state. Now another thing is the next state what it will move into, I'll write again. So this is the place where the sodium is entering in the cell. Now here what happens, the M gate is still open, but the H gate, what we wrote already, the H gate will close the channel. So here also sodium cannot enter because the H gate is closed. So this state is called the inactivated state of sodium channel. Inactivated state of sodium channel. Again after some time it will go back to closed state. Again it comes to the open state. So it has 3 states here. So I am just demonstrating here. Suppose this is the cell and sodium has to enter the cell. So when it has to enter, the sodium channel exists in these 3 forms, right? Now you may ask a question, sir, why these 3 states? Why the nature has given like this? The nature has given like this to make the tissues refractory. Suppose from phase 0 it is becoming, from open state it becomes closed. That means heart are highly prone for arrhythmia. So there is no refractive period only. So that's why whenever it is open, suddenly it will become inactive, then it will become closed, then becomes open. So this will make the tissues refractory. And that's why the heart is not prone for arrhythmia. So this is why 3 states are there. But when I am using a drug, antiarrhythmic drugs, where they will work and what channels do they block? Remember, they can block all the states, but there is some particular state which they are going to get attracted towards. So the class 1A is going to block the open state. The class 1A drugs are going to block the open state of sodium channel mainly. The class 1B, so the class 1B, particularly the lignocaine group, they are going to attach to the inactivated state more than open state. So they are going to block the inactivated state of sodium more than the open state. So this is the point. Sir, what about 1C? Now that's why I am writing 1C. It can block all the 3 states. All the 3 states can be blocked. Now if I look into the picture, which one seems dangerous? Just guess, take a guess. Yes, obviously 1C seems dangerous. The reason is it can block all the sodium channels. That is all the states. Problem is if it blocks all the sodium state, I told you when we block sodium channel, after some time it has to leave it. If it blocks sodium channel, then there is no action potential, patient may die. And please remember, antiarrhythmic drugs themselves can cause arrhythmia. So antiarrhythmic drugs themselves can cause arrhythmia if they block these channels for very long period. So that is a risk. So we understood the states of sodium channel and what do they do here. Okay, you are clear with this. Now once you are clear with this, okay, let me tell you the classes now. So in that we have class 1A drugs. Now this class 1A drug, they bind to the sodium channel for 1 to 10 seconds. Now this is the sodium channel. They bind to the sodium channel for 1 to 10 seconds, 1001, 1002, 1003 and then leave it. Class 1B drugs, they bind to the sodium channel for less than 1 second, not longer. But the class 3 drugs, they bind to the sodium channel for very long period, that is more than 10 seconds. So class 1A, class 1B and class 1C, they all bind to the sodium channel. Now what happens if they bind to the sodium channel? I told you, they bind to the sodium channel for 1 to 10 seconds. These bind to the channel for less than 1 second. And these bind to the sodium channel for more than 10 seconds. Suppose if I want to represent that in a graph. So again, these are important in INS pattern of exams. Let me tell you. So this is the phase 0 and this is the point where the sodium is entering. So this is the action potential. Now, this is what we mean by the slope of the curve. So this part is what we mean by the slope of the curve. I think most of you have studied differentiation integration in your 11th and 12th and you have forgotten. I will give an opportunity now to remember it. So slope of the curve is given by the formula dv by dt. So what happens when we block the sodium? The slope, which is straight, will become down. So the slope decreases and there is decrease in dv by dt. Now this is done moderately by class 1A drugs. Moderate. In 1B drugs, they decrease the slope dv by dt, might because they don't bind to the sodium channel for a very long time. So the slope is decreased mild. And class 1C drugs, very, very important. They bind for very long period. Obviously, they decrease the slope dv by dt. This is the slope marked very much, marked, very, very much marked. So I will repeat again. 1A bind to 1 to 10 second, 1B less than 1 second, 1C more than 10 second. And who is going to be dangerous? 1C are more dangerous because they bind to the sodium channel for a very long period. Now this class 1A drug, they also block potassium channel. Not only they block sodium, they also block potassium. Class 1B, they open the potassium channels. But class 1C drugs, they have no effect on potassium. No effect on potassium. Okay. Now I told you, if you block potassium channel, what will increase? The action potential duration will increase. Now keeping this point, we need to write the graph like this. How does action potential changes is an important question for you in the exam. So let us start our journey and you have to help in this. Yes, keep this point in your mind. First of all, I will write the class 1 drugs. Class 1A drugs. Now let me write the normal one first. So this is the normal action potential. Right. So what happens when I use class 1A drug? They decrease the slope. So I'll take this. So the graph will be like this. So there is moderate decrease in dv by dt, and along with that it will follow the same step. But what is going to increase is this. The action potential duration is going to increase. The reason is they block potassium channel. So the slope is decreased moderately, and what is also increased? The action potential duration is also increased. And that is the class 1A drugs. Now moving on to the next one, the class 1B drugs. Yes, can you guess that? Yes, let me write the normal one first. So this is the normal one. Now what happens when I use the class 1B antiarrhythmic? The slope is only mildly decreased, not so much. And what happens to the action potential duration? It's not going to decrease much. In fact, it will shorten up. Why it will shorten up? Why? Tell me why. Because they open the potassium channel. Now that is not a serious problem. You may ask a question, sir. You are telling that we have to close the potassium channel, but here you are opening it up. Now that function is very, very mild. Major action of class 1B drugs is to block the sodium channel and remove the excitability and make the tissue refractory. So the action potential is shortened for this. This is the graph for class 1B drugs. Now what about the story of class 1C, sir? Now please tell me. Class 1C, they cause marked decrease in dv by t and no effect on potassium. So if you keep that in your mind, let me draw this. So this is the normal one, and let us trace. So marked decrease. So there is marked decrease and the action potential duration won't change much. So the action potential duration remains same. So this is the graph for class 1C, the pink color. Now you try to compare all the three graphs here. So I have given the comparison here. Okay, class 1A, remember, they are going to decrease the slope moderately. They close the potassium channel, so the APT will get prolonged. 1B, mild. They open the potassium channel, so the APT decreases. 1C, what do? They marked decrease in dV by dt because they block the sodium channel for very long period, and no change in action potential duration. These are the graphs, very, very important. Okay, I hope you understood the graphs now. If they give you the image based question, you should be able to answer these questions. Okay, so let us start our journey. The classes of antiarrhythmics. So we are dealing with the class 1 antiarrhythmics. In that, the 1A antiarrhythmics. So what are the 1A antiarrhythmics? The name is called quinidine. The name is quinidine. And the another name is disopyramide. So don't confuse disopyramide with dipyridamole. Don't confuse disopyramide with dipyridamole because dipyridamole is an antiplatelet drug. One more derived from the local anesthetic procaine, it is called procainamide. Now please understand procaine, that is local anesthetic, they also act by blocking sodium channel. So again a correlation here. Sir, what are the specialties of this drug, quinidine? Now quinidine, the problem is it increases AV conduction. So the drug increases AV conduction. So what is the problem, sir? Suppose if I give it in atrial fibrillation, it will worsen that. So before you give quinidine, you have to block the AV node, then only you have to give this. Very much important. Second, it has so much of adverse effect. It's an alpha blocker. Obviously, it will decrease the BP. Second, it increases the release of insulin. So what happens? Patient may develop hypoglycemia. So monitor for this hypoglycemia. And it is a directly acting skeletal muscle relaxant. It's a direct skeletal muscle relaxant. And it has shown to cause diarrhea. And it is obtained from a bark called cinchona bark, a plant product or a tree product. So if you give this at high dose, it can cause something called synchronism. So what is characterized by synchronism is the tinnitus. So the ear problem, the eye problem is diplopia and CNS excitation. So this is what we see with quinidine, and because of so much of adverse effect, it's not being used so commonly now. So another drug is disopyramide. This drug has maximum anticholinergic property. Right, what is the problem? Yes, you know that it can cause dry mouth, blurring of vision, then tachycardia, then it can cause constipation and urinary retention. So because of that, this drug is also not commonly used nowadays because of the anticholinergic property. Now what we are commonly using now is a drug by the name procainamide. Procainamide is a derivative of the local anesthetic procaine. It's a sodium channel blocker. It has no or least anticholinergic property. Least anticholinergic property. So no problem, we can use it. And another important adverse effect you need to know is the drug undergoes acetylation. You know that drugs undergoing acetylation, ship drugs, P for procainamide. And procainamide is a drug which is known to produce drug-induced lupus. So it can produce drug-induced lupus. So patient on procainamide can come back with the malar rash, joint pains, and positive antinuclear antibodies. But when you stop the drug, the disease will also reverse. Can you tell me one more antihypertensive having the same problem? Start with H. Guess. Yes, obviously it is hydralazine. It is hydralazine. So you can remember these drugs by the mnemonic. Queen has depression and psychosis. Queen, depression, psychosis, these are the drugs. But mainly remember procainamide. Sir, where do you use this? Class 1A drugs, you can use it in both. VA means ventricular arrhythmia. AA means atrial arrhythmia. So they can be used for both the arrhythmias. You can use it in both. And I told you they decrease the slope, moderate, and they bind to sodium channel for 1 to 10 seconds. and they also block potassium channel. So what is the problem? They can cause QT prolongation. So if they are causing QT prolongation, which arrhythmia you should avoid? That's the question. So avoid these drugs in long QT syndrome. Moving on to the next one, that is class 1B drugs. Class 1B drugs, I told you, they decrease the slope only mild. The reason why mild? Why? They bind to sodium channel for less than 1 second and they can open the potassium channel. Sir, what are the drugs in this? The major drug is lignocaine. The major drug is lignocaine. Is there any other name for lignocaine? Yes, it is also called as lidocaine. So many times if they give in the exam lidocaine, don't get confused. They are both same names. Now, lignocaine is the drug which is used for ventricular tachycardia. It is used in ventricular tachycardia. Right. Now, why can't we use it in atrial arrhythmia? It's not effective. Remember, very important point, it's not effective. Not only lignocaine, any class 1B antiarrhythmics are not effective in atrial arrhythmias. So what are the reasons for that? Number one reason, it doesn't depress the SA node automaticity. SA node automaticity. Automaticity is not depressed by this. Second, it has no effect on atrial action potential duration and effective refractive period. So it has no effects on action potential duration and effective refractive period of atrial tissues. That's why atrial arrhythmia like atrial fibrillation, flutter, SVT, PSVT, they are going to check your knowledge whether lignocaine can be used or not. No, it is only used for ventricular arrhythmias only. Very important point. And the action potential of the atrial tissues are very brief period and the inactive state is very short period in them. So it cannot work effectively in atrial arrhythmias. So mainly it is used in ventricular tachycardia and also it is preferred in a patient with MI, myocardial infarction induced ventricular tachycardia. Now the question is why it is preferably used in ischemic tissues and ischemic tissue induced ventricular tachycardia, because these will bind to the inactive state and it will not allow the ischemic tissues to trigger an action potential. So they will only block the sodium channels of the ischemic tissues and the normal tissues are not affected. Normal tissues are not affected and only the ischemic tissues are affected. That's why they are most effective drugs in MI-induced VT. So many times they can ask in the exam, MI-induced VT, what may be the drug of choice? If there is no amiodarone in the option, you can choose lignocaine because it will affect the ischemic tissues and it will not allow the arrhythmia to occur, but it will not affect the normal tissue and normal conduction is not affected. So that's the reason. Now the question is, I will ask you the general pharma, can we give lignocaine orally? Never, because it is absorbed, but the problem is high first pass metabolism. You can give orally, but it has high first pass metabolism. So similar to lignocaine, we have come up with one more drug, which is a derivative of lignocaine. The name is called mexiletin. The name is mexiletin. It's a derivative of lignocaine. Now you can give it orally. The reason why it is given orally, because it has less first pass. Less first pass, that's the reason why it is given orally. Sir, where to use it? So obviously it's an oral drug. We cannot give it in emergency like VT. So it is used to prevent VT. Prevent ventricular tachycardia. Then it is used in a condition called a diabetic neuropathy. Now can you tell me why are we using it in diabetic neuropathy? Because you know lignocaine is a local anesthetic. Mexiletin also produces that local anesthetic effect. Neuropathy is a pain. So we don't want a pain sensation. So we use it. So lignocaine, mexiletine, the older drugs are tokainide and an anti-epileptic drug, phenytoin. So these are not used nowadays. Just for your information, they are also called as class 1B antiarrhythmics. So you can remember by the mnemonic, lignocaine undergoes MTP, medical termination of pregnancy. Lignocaine, MTP, M for mexiletine, tokainide, and P for phenytoin. So phenytoin is an anti-epileptic drug. It was used earlier as an antiarrhythmic, but not now. So we have only two drugs here, lignocaine and mexiletine. So once we understand this, let us come to one more important class, that is class 1C drugs. So they decrease the slope marked. Now why there is marked decrease? Because they bind to sodium channel for more than 10 seconds. More than 10 seconds. What happens to potassium? Potassium is not affected. No effect on potassium channels. Sir, what are these drugs? These drugs are the EPF. I think most of you heard of the Employment Provident Fund, EPF. When you go join a government job, you'll know that EPF. So E stands for N-canide. If you know canide, one more canide is flecainide. And P for propafenone. So these are the three drugs in class 1C. This propafenone has beta blocking property also. It has beta blocking property also. Very, very important. Flecainide is used for prophylaxis in a condition as a prophylaxis in a patient with WPW syndrome. Wolff-Parkinson-White syndrome. I'll explain that in the later stage. Now, flecainide, propafenone, N-canide, these are drugs. But the problem I told you, these drugs are most arrhythmogenic. And I told you the reason for that, because they block the sodium channel for a very long period. And that's the reason they are contraindicated in a patient who has structural or ischemic heart disease. So in these conditions, the arrhythmia will increase. So don't use it in structural or ischemic, that is MI patients. We should not use these drugs. Class 1C drugs, N-canide, propafenone and flecainide, these are the things. So, sir, where do we use class 1C? Is it also same like lignocaine? No. You can use them for both ventricular arrhythmia as well as atrial arrhythmia, but don't use them in structural heart disease or ischemic heart disease. They can increase the risk of arrhythmia. So let me summarize the things. Class 1 are sodium channel blockers. 1A are quinidine, disopyramide, procainamide. Queen, depression, psychosis. Class 1B are lignocaine. So lignocaine has MTP, mexiletine, tokainide, phenytoin. Class 1C EPF, N-canide, propafenone and flecainide. And remember, 1A and 1C, you can use it in both arrhythmias, but 1B drugs are only used in ventricular arrhythmias. They are not effective in atrial arrhythmias. And I have told you the graphs also. Okay, so that is about the class 1A, 1B and 1C drugs. So once we are done with this, let us move on to the second class of drugs. We have discussed them already. The class 2 drugs, they are nothing but the beta blockers. So these are beta blockers. So the commonly used beta blockers like propranolol, nadolol. Then we have another drug, and the shortest acting beta blocker, esmolol and metoprolol. So these two drugs can be given IV. So they are used in emergencies. Now, beta blockers. Beta blockers, as we know, they decrease the heart rate and they decrease the conduction. So they are known to decrease the heart rate and decrease the conduction. So where to use beta blockers? Beta blockers can be used in the atrial arrhythmia as well as ventricular arrhythmia. So this is the basics we need to understand. What are the atrial arrhythmias? I can use it. You can use it in atrial fibrillation and atrial flutter. Now what do? They decrease the conduction, that is they act as AV blockers. Ventricular arrhythmias, you can use it in ventricular tachycardia. There is something called ventricular premature beats. Ventricular premature beats. And it is the drug of choice for beta blockers are drug of choice for congenital long QT syndrome. Congenital long QT syndrome. These are the conditions where we use it. Right? So the ventricular tachycardia, ventricular premature beats, drug of choice for congenital long QT syndrome. Right? So these are the uses of beta blockers. We have discussed them extensively in the ANS as well as in other parts of CVS. So here again we are coming back with beta blockers. The propranolol, nadolol, esmolol, metoprolol. The uses are in both atrial arrhythmia as well as ventricular arrhythmia, that is class 2 drugs. Okay, so moving on to the next category. These are called class 3 antiarrhythmics. Now what are those? They are nothing but they are potassium channel blockers. Now what do potassium channel blockers do? They increase the absolute refractive period, thereby they increase the effective refractive period. So that means the tissues become refractory. So because of this, they can convert an abnormal rhythm into normal sinus rhythm. Normal sinus rhythm. I told you this. So this is what we mean refer by the pharmacological cardioversion. Second, since they increase the action potential duration, what do they do in ECG? They can cause QT prolongation. The drugs can cause QT prolongation. So the drugs can cause QT prolongation. So they increase the action potential duration, they increase the effective refractive period and make the tissues refractory. They make the abnormal rhythm into normal sinus rhythm and they can cause QT prolongation. So once we understand this, so what are the drugs we use in this case? So we can use a drug by the name Varnacalant. Varnacalant is called as multi-ion channel blocker. Not only this, it blocks other ion channels also. It is called as multi-ion channel blocker. Okay, Varnacalant, a old drug, bretylium, not used nowadays. Previously, it was used in arrhythmias, not now. Now we have a drug called ibutilide. The name is ibutilide. Then the famous drug amiodarone. Amiodarone, very, very famous drug. Then we have sotalol. Sir, you told lol is beta blocker, then they should be in class 2, right? This is a beta blocker having potassium channel blocking property also. That's why they have placed it in class 3 antiarrhythmics. Very much important, and the examiner can confuse you with this. So please keep that in mind. If you know amiodarone, we have another drug that is called dronedarone. Dronedarone. And if you know ibutilide, we have one more drug called dofetilide. So you can remember these drugs by the mnemonic very biased drugs. So very biased drugs. Only thing is E is missing, that's it. That's why they are biased. They are missing the E. So Varnacalant, bretylium, ibutilide, amiodarone, sotalol, dronedarone, dofetilide. Now if you read the name, the amiodarone, it has iodine in the name. The difference between amiodarone and dronedarone is it doesn't have iodine. No iodine in this. Otherwise they are same. Now in these drugs, the maximum QT prolongation is done by the ibutilide and the minimum QT prolongation is done by amiodarone, but it will also cause, but minimum in all the classes what you discussed here, in all these drugs what you discussed here, that is minimum. Sir, where do you use class 1 drugs? Class 3 drugs, where do you use it, sir? Class 3 drugs, we use it in both atrial arrhythmia as well as ventricular arrhythmias, both. I told you when I discuss atrial fibrillation, atrial is fibrillating and we can block the conduction. Then who will convert atrial fibrillation to normal sinus rhythm? These are the drugs. Class 3 drugs. I'll give an example. In atrial arrhythmia, they will convert atrial fibrillation into normal sinus rhythm. And that is what we mean by the pharmacological cardioversion, where we make the rhythm into normal. That's the point. Now, in all this, the most important drug you all should remember is amiodarone. Very, very important drug. Amiodarone is very, very important. The reason is it has multiple mechanism of action. Major is potassium channel blocker, but the minor mechanisms are it's a sodium channel blocker, it's a calcium channel blocker, and also it has beta blocking properties. So it's like it has all the properties. Sir, where do you use it? It is used in both atrial arrhythmia as well as ventricular arrhythmias. But it is contraindicated. Which arrhythmia? Long QT syndrome. Why? Because it itself prolonged QT interval. Don't give it. Otherwise, it's one of the best drug for both atrial arrhythmia and ventricular arrhythmia. The name is amiodarone. It has multiple mechanism of actions. So many times I call it as dawn of antiarrhythmic. Amiodarone. Dawn. Okay. So what is the pharmacokinetics? What should I remember for this? Pharmacokinetics. Remember, it's an enzyme inducer. No. It's an enzyme inhibitor. It's an enzyme inhibitor. Next, it inhibits a protein called P-glycoprotein. Now, I have discussed that with digoxin. So, by inhibiting P-glycoprotein, it can cause digoxin toxicity. So, that's why in digoxin toxicity, we avoid using amiodarone because it will increase that. And what is seen in digoxin toxicity? Arrhythmias. So, try to avoid amiodarone in digoxin-induced arrhythmias. What is the drug of choice for digoxin-induced VT? Lignocaine. Digoxin-induced SVT, beta blocker. So, we never mentioned amiodarone there. Yes. Now, it has a very long half-life, very long. How much? It's around 3 to 8 weeks. So, it is a long-acting drug. And it contains 37% of iodine in the structure. So, iodine. Now, when it is iodine, there is a chance it can cause allergy phenomena. Right? The most important thing is they will ask you the adverse effect of amiodarone. Very much important. Adverse effect of amiodarone, repeatedly asked exam question. Please mark it. This is the one which you should study more. The mnemonic is please check. Please check LFT, then TFT, PFT, and also check for allergy. So when you are using amiodarone, please check this. So what is P for? The drug can produce photosensitivity. Now this photosensitivity is seen in the sun exposed areas and the man looks like bluish, so it can cause blue man syndrome. Patient may have blue man syndrome. The skin is also called as the Smurf skin. And recently the image based question was asked about this. What drug will cause it? Second, it can produce one more, the P for peripheral neuropathy. It can produce peripheral neuropathy. Then what to check for? Check the eye. Check the eye. When you think of eye, check two things. The cornea. Check the cornea. So it can cause corneal microdeposits. corneal microdeposits, and we call it as cornea verticillata, or it is also called as vertex keratopathy. And also check the eye for optic neuritis. The drug can produce optic neuritis. Both have been asked as a question in the recent exams. Both have been asked. Then LFT. Why LFT? Because it can cause liver toxicity. So monitor the LFT, liver function test. Now TFT. Why you have to monitor TFT? Because it can produce thyroid dysfunction. Sir, what is thyroid dysfunction? Is it hypo or hyperthyroidism? Guess, what is it? Yes, it's both. It can produce both. Why, sir? Because iodine. Because of iodine, it can cause both hypo as well as hyperthyroidism. And that's the reason you have to check the thyroid function test. PFT stands for pulmonary function test. So it can cause pulmonary fibrosis. So recently this also came in the exam. Patient has interstitial lung disease. Which antiarrhythmic will you avoid? Amiodarone, because it causes pulmonary fibrosis. Now why allergy? The reason is because of the iodine content, and it can also produce rash. So that is about the adverse effect of amiodarone. Many a times the questions have come. So please, photosensitivity, the blue man syndrome, peripheral neuropathy, check the eye for the corneal deposits and optic neuritis, LFT liver toxicity, PFT pulmonary function test, TFT thyroid dysfunction, and allergy can be seen, and rash can be seen with this drug. So that is about a very beautiful drug for your exam. Amiodarone, not only for exam, it's a very beautiful drug to treat arrhythmias. Now once we are done with that, let us move on to the next class. The class is class 4 antiarrhythmics. They are calcium channel blockers. So which calcium channel blockers are we using? They are non-dihydropyridines, non-DHPs. Can we use dipins, amlodipine, nifedipine? No, because they don't work on the heart. So what we are using is verapamil. And one more drug is diltiazem. So what do? They decrease the heart rate. They decrease the conduction, similar to the beta blockers. So where to use it, sir? We mainly use it in atrial arrhythmia, and very less we use it in ventricular arrhythmia. So atrial arrhythmias like SVT, PSVT, flutter, fibrillation. Ventricular arrhythmia, usually we avoid this because calcium is required for the contraction of the heart. If you are using that, there is compromisation of the force of contraction. That's why we try to avoid it in ventricular arrhythmias. But it is mainly used for atrial arrhythmia, that is verapamil and diltiazem, right? Once we are done with that, it's time to discuss the miscellaneous group. Miscellaneous. What are the miscellaneous? You already know them. Atropine is miscellaneous. I have written that. Digoxin is miscellaneous. Then magnesium sulfate is miscellaneous, and it is the drug of choice for torsades d pointis. It is nothing but acute attack of long QT syndrome. Long QT syndrome. So it's a type of ventricular tachycardia where the QT interval is prolonged. Then we also use potassium chloride infusion, where it is used in chronic digoxin toxicity induced tachycardia. Chronic digoxin toxicity. Now please keep this point in your mind. Never give potassium in acute digoxin toxicity, because acute digoxin toxicity potassium is already high. So don't give it. Chronic digoxin toxicity, we use potassium to manage tachycardia. So the drugs are atropine, digoxin, magnesium sulfate, and potassium chloride. The last miscellaneous drug what we are going to discuss, it is called the adenosine. Now adenosine we already know, it is nothing but it is present in adenosine triphosphate. So what we give adenosine as a drug, when we give it IV, is it long acting or short acting? Obviously it's very short acting. If you check the half-life of the half-life of the drug is less than 5 seconds. Now you may ask a question, why it is very short acting? When we give adenosine into the vein, the cells of the vein itself will take it up because everybody require ATP. So adenosine is taken up. So the RBCs and the endothelium, when we give it IV, they will rapidly take it up. So they will take up adenosine, and that's why it's very short acting. The question here is, if it is very short acting, should I give it very slow or very fast? Point number one. Point number two, should I give it in the peripheral vein or should I give it to a central vein close to the heart? Yes. So if you are giving it in a vein, IV, it is better to give more in a central vein. And when you are giving it, you have to give rapidly. So we call it as rapid bolus should be given. These are pharmacokinetic importance. You should push it rapidly and preferably given in a central vein. Now where to use it? It is used in two important conditions, PSVT. Now PSVT is paroxysmal supraventricular tachycardia. It's a paroxysmal means sudden and successive. It will come and go. So it's a short duration. So we use a short acting drug, that is adenosine. It can also be used in SVT. For both the condition, it is a drug of choice, adenosine. Now once I know the uses, but how does it work here? What is the mechanism of action? Now, do you remember when I discussed the nodal tissue? I told you nodal tissues have M2 receptor. Now, who will activate M2? Acetylcholine will activate M2 receptors in the heart and it decreases the heart rate and conduction. Now, how does it do? I told you M2 decreases the cyclic EMP and increase the entry of potassium increase the potassium exit out of the cell. So when the potassium exit, the cell become hyperpolarized and the cell is depressed. So this is the basics. Now what is the mechanism of action of adenosine? It stimulates acetylcholine sensitive potassium channel. So it stimulates acetylcholine potassium channel. So what happens? Potassium goes out and the tissues will be less excitable, so it will decrease the heart rate and conduction. It will decrease the heart rate and conduction. That's the reason why it is used in PSVT as well as SVT. So major action is to stimulate acetylcholine sensitive potassium channel, decrease the heart rate and conduction. Very important. So you know the pharmacokinetics, use and mechanism of action. What is the adverse effect? Sir, it's a very short acting drug. Do the drug also produce adverse effect? Yes. It can produce asystole. But remember, the asystole is transient. Why? Because it's short acting. One more problem is it can cause atrial fibrillation. Atrial fibrillation is also transient. Remember, the asystole and atrial fibrillation are transient. That means they don't last longer. The question recently asked is, what drug is contraindicated in atrial fibrillation? It is adenosine. Adenosine should not be given in a patient with atrial fibrillation because it itself can exaggerate that. Very much important. Please note down that point. So asystole, it can cause bronchoconstriction. So which patient I cannot use? It is contraindicated in asthma patient because it's a bronchoconstrictor. It can produce chest tightness. And D for it is a dilator of blood vessel. So it is a dilator of blood vessel. So dilation of blood vessels. And because of dilation of blood vessel, obviously the patient will have flushing. So remember the adverse effect as A, B, C, D. And these are all not long-term adverse effect. It's a short because the drug is going to work very short period. Now you understood these things. Where it is contraindicated, I repeat again, in asthma patient, it is contraindicated in atrial fibrillation. Very important point. Please note down that. Now, one drug interaction is also important for adenosine. What is that? Methylxanthines, they decrease the activity of adenosine. Methylxanthines decrease the activity of adenosine, and a drug called dipyridamole. Dipyridamole is an antiplatelet drug which increases the activity of adenosine. Sir, why should I know this drug interaction? Methylxanthines are nothing but the theophylline, aminophylline, even the caffeine. Suppose the patient has taken these methylxanthines and he had this SVT, PSVT, and you have to give adenosine. Now tell me, will you give the normal dose, increase the dose, decrease the dose? Pause the video and try to answer this. Now, since it decreases the activity of adenosine, already patient on methylxanthines, what should I do? I should increase the dose of adenosine and give to the patient. Then only it will work effectively. Suppose the patient is already on dipyridamole, it increases the adenosine activity. So if I have to give the adenosine to this patient, I have to lower the dose of adenosine and give. That is the application part. That's the clinical application. Clear? Now, if you remember, dipyridamole also causes coronary steal phenomenon. Why it causes coronary steal phenomenon? Because dipyridamole action is by increasing adenosine. The coronary steal phenomenon is because of increased adenosine activity. Even adenosine can cause coronary steal phenomenon. One more adenosine receptor agonist, regadenoson, which is used in cardiac stress testing, that is also going to cause coronary steal phenomenon. And we use dipyridamole, adenosine and regadenoson in cardiac stress testing. Why? Because they cause coronary steal phenomenon and they cause the ischemia changes, and that can be read in ECG. So this is the application. Drug interaction we understood. Once we understood, let us come back to this. We started our journey with understanding the types of arrhythmias, and I told you there is bradyarrhythmia, heart block, we use atropine and discipline, correct. Now what about SVT, PSVT? Now SVT, PSVT, the drug of choice here is adenosine. Now adenosine is a bronchoconstrictor. Suppose a patient has PSVT and is asthmatic, then I cannot give adenosine. Then what is the alternative? It is verapamil. For SVT, you can give adenosine. If that is not in the option, you can give verapamil. So these are the drugs. Now atrial fibrillation flutter, I told you, we use AV blocking drugs like beta blocker, CCBs, non-DHBs, digoxin. So these are the AV blocking agents. Now how do you bring the rhythm to back? To make the atrial fibrillation to normal sinus rhythm, what are the drugs we use? Any guesses? Usually we give the class 3 drugs, that is amiodarone, ibutylite, then vernaculant, these drugs, or we can use the class 1A drug like procainamide. They are used. So they are going to bring the atrial fibrillation to normal sinus rhythm, and that is what I was telling you repeatedly, pharmacological cardioversion. Any tachyarrhythmias, if the patient is unstable, the best thing is to do the DC cardioversion. If it is stable, then only go for the drugs. Now moving on to the ventricular tachycardia. For ventricular tachycardia, the best drugs are amiodarone. If that is not there, you can prefer to give lignocaine. If it is not there, procainamide and beta blockers are given. So these are the 4 options what we have for treating ventricular tachycardia commonly. So amiodarone, lignocaine. Most of your exam question, they can ask you amiodarone or lignocaine. Sir, what about ventricular fibrillation, pulseless VT? Now the patient is absolutely unstable here. Then you cannot wait for the drugs. You have to defibrillate, and if the patient is not responding, then only we have to go for the drug. Either amiodarone or lignocaine can be used. So this is how we manage. So even in VT, if the patient BP is low, then you have to go for DC cardioversion only. Another tachycardia condition that happens is a long QT syndrome. Long QT syndrome. What is long QT syndrome? It's nothing but it's a tachycardia It's a ventricular tachycardia with QT interval prolonged. So it can be by birth, congenital. For congenital, the drug of choice are beta blockers. It can be acquired. Acquired are by drugs. So what drugs can cause it? Just now, can you tell me which class of antiarrhythmic can cause this? The class 1A, class 3. Can you tell me some antibiotics which can produce that? Bedaquiline can cause QT prolongation. The fluoroquinolones, FQs means fluoroquinolones, macrolides. Okay, there are many drugs, we'll discuss it later. So these drugs can cause it. So what to do that time? Stop the drug. So stopping the drug will stop that long QT syndrome. But suppose a patient has acute attack of this, acute attack of long QT syndrome, or the torsades de pontes, then what is the drug of choice? Anybody? Anybody? Yes, you know the answers. Come on, guys. Yes. What is the answer? Magnesium sulfate. Magnesium sulfate can be used for managing torsades de pontes. Okay, sir, we understood all this thing, but there is one more arrhythmia. The arrhythmia is there is an accessory pathway connecting the atria and ventricle. So we call it as a syndrome called WPW syndrome. So the syndrome is WPW syndrome. So the problem in WPW syndrome is there is an accessory pathway. So there are treatment for this. The treatment of choice, remove that accessory pathway. The removing is what we mean by the term ablation. So radiofrequency ablation is the treatment of choice, remove it. But until the patient undergoes surgery, has to be put on prophylaxis. And the prophylaxis is done by the drug called flecainide. Flecainide is used for prophylaxis. And if a patient develops arrhythmias in WPW syndrome, we can treat it with the drug called procainamide. Procainamide can be used. So this is about WPW syndrome. But one important thing they will ask in the exam, I'll just write here. Now a patient has atrial fibrillation and he has WPW syndrome. Now what drugs should we avoid? What antiarrhythmics are avoided? What are avoided? Yes. Now let me tell you the story here. This is the heart. And you know that normally SA node, then AV node, bundle of His, then Purkinje fiber. These are the conducting system of the heart. I told you the car story. First gear, second gear, third gear, fourth gear, like that. Now what happens if there is an accessory pathway? This will connect directly the atria and ventricle directly. Now when there is atrial fibrillation, the atria is firing. Now who was blocking that impulses? The AV node. Now if you use the drugs which block AV node further, this will not function. Then the only pathway is this one. So all the impulse will go from atria to ventricle, and the ventricle may have tachycardia or fibrillation. So you are making the arrhythmia worse. So you should not block the AV node further. So which are avoided? AV blocking agents are avoided. Sir, what are the AV blockers in this case? You can remember A, B, C, D. Sir, what is A for? Adenosine. Should not be used. B for beta blocker. C for CC base. And D, any guesses? D, any guesses? Obviously, digoxin. Should not be used, particularly where if the atrial fibrillation with WPW syndrome. So I'll just take the example of car. If you are going from one gear, second gear, no problem. But if the car jumps from first gear and immediately to the fifth gear, either the car will jump or it will stop. So that's why the impulse should not be allowed here. And sir, why do you prefer class 1C drug, procainamide or flecainamide here? The class 1C drugs increase the refractory period of accessory pathway. I told you what is refractory period. The tissues will not get excited. So that refractoriness increased by the drug procainamide, flecainide. That's why they are preferred there. So that is about the antiarrhythmic drugs. Now, most of the times when we start a class antiarrhythmic drugs, Your student feel that what is arrhythmia, what is the drug used. So make it simple. First of all, you should know the basics. Arrhythmia means heart is not beating normally, either beating too fast or too slow, brady or taking. The problem is in the impulse generation or impulse conduction. There are arrhythmia arising from atria, SVT, PSVT, flutter fibrillation, ventricular tachycardia fibrillation. They are tachyarrhythmias. There may be accessory pathway called WPW syndrome. The atria SA node can also generate low impulse, that is bradycardia, AV block. For that we use atropine or isoprene. Whenever there is SVT, PSVT, we have to block the conduction. So we use adenosine or verapamil. SVT, PSVT, the drug of choice is adenosine. But in atrial fibrillation flutter, we have to block the conduction. We use beta blockers or CCBs. And we need to bring the rhythm normal. And what we do is, we use the class 3 drugs or class 1A drugs to make the rhythm to normal. Now remember, any arrhythmias, patient is unstable, give the DC cardioversion, stable, give the drugs. VT, we use amidron, lignocaine or procainamide beta blocker. Any VF, any pulseless VT, you have to defibrillate, then give the drugs. Drug of choice for torsades de pointes is magnesium sulfate. Congenital long QT syndrome is beta blocker. And remember, there are 4 important classes of antiarrhythmics. Class 1 is sodium, class 2 is beta, class 3 is potassium, class 4 are CCBs and miscellaneous. 1, we have 1A, 1B, 1C. 1A, quinidine, disapirin, procainamide. 1B, lignocaine, mexiletine. 1C, EPF, encanide, flecainide, propafenone. And remember, class 1B are used only for ventricular arrhythmias, others are for both. Class 2 are beta blockers. Class 3 are potassium channel blockers, they can cause QT prolongation. Main drug is amidron. Remember the adverse effect of amidron, the TFT, LFT, PFT, the Blue Man syndrome, the corneal deposits, optic neuritis, allergy, peripheral neuropathy, very much important. Class 4 are CCBs, only we use verapamil DTSM. Adenosine, pharmacology I have told you, drug of choice for SVT, PSVT, avoid it in atrial fibrillation. Right, this is the summary you have to keep in your mind. Thank you all, that is about antiarrhythmics. Thank you.